right. Wow, we've got a great crowd. Good morning and welcome to everyone. My name is Peter Long. I'm the President and CEO of Blue Shield of California Foundation, and I'm glad that many of you have joined us here today in the room and online. We have 530 registrations. Shows you, as Sandra Shuri said to me when we were walking in, if you put the words Medicaid Waiver, California, and health affairs together, that's a great combination that piques people's interest. So we're glad that you're interested. We should be receiving feedback any day from CMS on our waiver proposal, on the state's waiver proposal. So it is an exciting time, and it's the perfect time to have this conversation among all the stakeholders. But I'd be remiss if I didn't, before we jump into the substance, if I didn't recognize all of the people in this room and folks online and across the state who poured your great ideas into the state's waiver proposal. I can say this was an incredibly robust and rich and deep conversation that led to our waiver proposal. People really did give their best thinking to these ideas, participated in the work groups, and so I think it's actually a testament to the kind of quality of folks in the room, but also the cohesiveness of our state. And so before we get into the details and talk about the waiver and what's going to be in and what it looks like on day 1 and day 2 and day 100, I think it's really important just to recognize all that work. And the second is to thank all of the folks. We would not be here if the amazing work hadn't happened on our current waiver. And just to recognize that we are in a radically different place today in June of 2015 than we were in 2010. I mean, the ACA obviously, but I think a lot of that has to do with the work that happened under our current waiver. So I just wanted to set that context before we dive in and talk about what comes next. It's really important to understand what's come before it, and that all of us in this room are a part of this conversation and have been. I'll be very brief. I just want to make a couple of comments. Why is Blue Shield of California Foundation interested in this? This is it. I think this is our game, in a sense, of the transformation of the healthcare safety net and the Medi-Cal program. The 1115 waivers have become the primary vehicle to transform both the healthcare safety net and, frankly, to transform Medi-Cal. They really are the state's experimentation. So whether it's the next version of the DSRIP, or it's the safety net care pool, or whole person care, or the payment pilot for FQHCs, which is not in the waiver, I know, but if it's any of those things, that is the future. That's healthcare 2.0 or ACA 2.0 in our mind. What I'd like to just put in one infomercial, like you get to get up here and you get one infomercial. And so my one infomercial, and hopefully it will resonate with each of you, is the criticality of sharing our definition of success. And people who've heard me will know that this is an issue that's near and dear to my heart as a health services researcher. But just that we take the time in our waiver deliberations as we finalize the waiver and we implement it, that we really take the time to talk through what our shared definitions of success are. And that is both about our values and the value of healthcare. So it ultimately is about our values collectively of the healthcare system that we want to have in California, and particularly for low-income and vulnerable populations. And then it's about the nuts and bolts of what we measure, how we measure it, where we collect that data. So I just want to call that out. And we have a recent report from the Institute of Medicine that Blue Shield actually and California Healthcare Foundation and Robert Wood Johnson funded, called Vital Signs, which gave us some food for thought, gave us a lot of food for thought, and proposed 15 measurement domains around what would be a healthy U.S. healthcare system. And they're pretty radical. If you really step back and look at them, they really look at the health of the population. They kind of take the triple aim a little bit further and look at things like unintended pregnancy and other just health of the population. So I was saying to someone, if you were a cardiologist in Ventura County, you might not see a lot of yourself in those 15 domains. You'd have to look pretty hard from where we are today, deep inside the healthcare system with thousands of measures that are burdening the healthcare system and I think holding us back from value, to get to 15 domains that really do measure the health of the population and our overall well-being. So I'd commend us to look at that as we're talking, but more importantly, to continue to have the conversation about what success looks like. Because my premise is if we don't have that conversation, we're off the track already, and if you don't know where you're going, anywhere will do. Before I turn it over to Sandra, I just want to acknowledge, while it takes a big village to put together an 1115 waiver proposal and a really big village to implement an 1115 waiver, it takes a small village to put on a conference like this or a workshop like this. So I want to acknowledge Debbie Boylan and Alan Weil and the folks from Health Affairs, Kimberly Weber and Christine Mulhart from Blue Shield of California Foundation, and Avram Goldstein and Sandra Shuri and others from the California Healthcare Foundation in organizing this event. So let me just thank them for their work. And I don't get to do this often. I have the distinct pleasure of introducing Sandra Shuri, who is the Vice President for External Engagement at the California Healthcare Foundation and a friend and partner of mine and the Foundation's, and has had many big, important roles and done many big, important things. So with that, I will turn it over to Sandra.
Thank you, Peter. Good morning. My role is also to welcome you and thank you for being here today. Thank you, Peter, for those kind words. I really want to welcome all of you who are here in person and on the web. How amazing it is to live in a state with such a diverse and talented cross-section of people who are passionate about the Medi-Cal program and the promise it offers to really improve the health of Californians. It's just an amazing riches we have. CHCF, the California Healthcare Foundation, in partnership with our sister philanthropies, Blue Shield of California Foundation and the California Endowment, provided support for the extensive stakeholder process that led to the submission of the 1115 waiver. And that process was long, it was painful, there were a lot of meetings, a lot of background readings, but that waiver that is sitting at CMS is so much stronger, broader, and rich than it would have been without all that input that I just wanted to pause and give a shout out and thanks to all the people across the state who participated in those stakeholder engagement and worked with state colleagues to enhance the waiver. The existing Bridge to Reform waiver is something this state is so proud of. It provided essential funding and flexibility to start that transformative process in Medi-Cal, and combined with the policy and financing options in the ACA, really has been a 5-year period of incredible change. Just to tick off 4 of the big things that come to everyone's mind, but to put them in there. In 2010, when that waiver started, 7.5 million people in Medi-Cal. Today, 12. In 2010, some managed care. Today, the dominant delivery system, bringing accountability, performance requirements for access to care, quality, and care of cost to members in the Medi-Cal program. 2010, mild to moderate mental health conditions were kind of covered, maybe yes, maybe no. Today, an explicit requirement in the benefits to provide coverage for those conditions. And then the federal incentive payments in the waiver that have really been so important to our 21 public health care systems. Those are tied to goals of transformation around infrastructure development, innovation, redesign, population-focused improvements. The current waiver really has put this state on a course that we cannot afford to have a pause or a blip or a bump in. The task of transformation is engaged at all levels of the Medi-Cal program, but it's not done. The next federal waiver is our best opportunity to keep that momentum going and to really improve the programs and get the kind of outcomes we want from the program. What are those outcomes? You know, we shorthand them, call them the triple aim, but of course it's always good to shout them out. Better care, safer care, easier access, and lower costs. Our state policymakers understand that role of transformation, that it's going to take investment in our delivery system to get those changes, and the waiver is really a reflection of that. This morning's discussions are a great opportunity to remind ourselves of the significance of the next waiver, to reaffirm our mutual interests in system transformation, and to look towards ways we can help in the successful implementation. Peter said, gee, we're just days away from feedback from CMS. My message on the timing is we are still really early in our state leaders' negotiations with the federal government. During this negotiation period, it is my opinion that it is essential that our state's stakeholders stand in unison and give voice to the shared aims and shared visions in that waiver. Doesn't mean we agree on everything, doesn't mean everything was written just the way your particular view would have had it. But we have to, as a state, pull together and let policymakers in Washington know that we need help with the transformation of our delivery system and that we're on a path to get there with their help. Each of you are leaders and change makers. Let's continue to work together. We need these next 5 years with the new waiver to be just as transformative as the last 5 have been. So welcome, thank you for being here today. It is my distinct pleasure to introduce a longtime buddy of mine, Alan Weil, official National Smarty Pants. That is a high honor. And then in his day job, Editor-in-Chief of Health Affairs. Alan.
Thank you, Sandra, and thank you, Peter. It is great to have all of you here. To those of you in the room, my apologies for the patience you're going to need getting a chair. In Washington, you hold an event, people sign up and they don't show up. So in Sacramento, they actually arrive, and we maybe undercounted the number here, but we're thrilled that you're all here and appreciate your patience. Our appreciation at Health Affairs goes out to the Blue Shield of California Foundation, the California Healthcare Foundation, for making this event possible. We do tend to get stuck in our work in the Washington area. It's a great joy to get out of Washington and to come here and be able to sponsor this event that is on such a timely and critical issue. I always love coming back to California. It's where I'm from. I wore my blue and gold tie. I'm a Cal grad, a graduate of Berkeley High School. I had to pay a little extra to come this time because of the extra weight charge bringing water in my bags. But other than that, it's really great to be able to be here. I'm always struck when I'm here talking about healthcare and health policy, something that has struck me from the outset, which is, on the one hand, California is the home of what is often held up as the primary model of integrated care in the United States, the Kaiser system. We just had a blog post talking about the growth of accountable care organizations, more so in California than anywhere else in the country. Efforts to promote system integration, in many respects further along here, writ large, than they are elsewhere. And yet, when we come and talk about Medi-Cal, the Medicaid program, it's a different conversation, and I've been struck over the years about why we have that contrast. Part of it is by design, in many respects by design. California built a somewhat separate delivery system for Medi-Cal than it did for the commercially insured population. And that boundary led to very different systems developing with different characteristics. The funding mechanisms that you all know better than I that have evolved over the years. I lived here when Proposition 13 was passed and local funding disappeared and got replaced by state funding. Now state funding's disappearing and it's getting replaced by local funding or federal funding if you can get it. The supplemental funding models that you've used have perpetuated a separateness in the Medi-Cal system, and of course the primary role that counties play at multiple levels, in administration, in being the hosts of the delivery system, just in general, when it comes to social services, California stands out as having a dominant role for counties. And so you have these two systems that are all interested in performance, but often not talking to each other and not interacting as much. And now here we are, as you're looking at the waiver renewal, and Sandra just went over some of the accomplishments from the first round, and there's such an opportunity to move the system forward for those who most need it as the Medi-Cal program has grown. And it's a pleasure for me, as an observer, not living here anymore, to see how much energy and effort is going into the improvements that you all are working on. It's also fun to be here because I spend a lot of time around the country, and of course the Affordable Care Act is not exactly equally popular among everyone that I speak to and every state that I go to. I don't want to deny that there's a disagreement about policy here, but it's also interesting and a pleasure to come to a state where each time I'm here, I'm reminded that people aren't rehashing the debate over the merits. They're trying to figure out what to do with the law and where to go and how to make it work in California. And I think that's reflected in part in the broad stakeholder process that has also been mentioned, that in many places there's so much suspicion and mistrust that when waiver negotiations begin and waiver discussions begin, people hold everything to themselves. It's hard to get information. Part of the joy of having the session today is knowing that we're building on a process of engagement that's already included those of you in the room. So what are we trying to do with the event today? Remind all of you and all of California why you're undertaking this journey, what's at stake, not just financially, which I know is often the focus, but from a care system improvement perspective, what's at stake in the renewal going forward, what will it take to achieve the goals that have been discussed, and that's what we're going to do today in our short time that we have. I'm going to keep the discussion moving as quickly as I can. We have two panels. The first panel will draw from the research and the literature. What have we learned in California and outside as we think about health system transformation in the Medicaid program? And then the second panel will give you the perspective of those who are working on these issues at leadership levels inside and outside state government. I can't stand at a podium without holding up an issue of Health Affairs. Make sure you know what it looks like. This is June. It just came out a couple of days ago, but I want you to be sure that you know, if you didn't see the flyer out front, that the July issue has a large collection of papers on Medicaid, two of them actually authored by speakers in our first panel here. So if you don't get enough Medicaid today, I know you'll want to come back in July and see what we're releasing at that point. So it's now my pleasure to move us into the first panel, which is looking at how waivers are being used to promote system improvement in Medicaid. I am going to quickly introduce our three speakers and then have them come up and present their work in turn. Nadi Porat is the Director of Research at the UCLA Center for Health Policy Research, Professor of Health Policy and Management at the UCLA Fielding School of Public Health, and an adjunct professor at the UCLA School of Dentistry. She'll be followed by Michael Guzmano, a research scholar at the Hastings Center, where his research focuses on health and healthcare inequalities, and Andy Beinman, a professor of medicine and epidemiology and biostatistics, and the director of the California Medicaid Research Institute at UC San Francisco. So to get us going in a discussion of what we've learned so far, let me turn it over to Nadi.
Good morning. Thank you for the introduction. I'm going to hopefully move very quickly and talk about some of the specific activities that have been happening in California, moving too quickly, towards all of the activities that have ended up with efforts to build systems of care in the safety net. Okay, there we go. Quick framework to sort of orient ourselves to the type of activities that have happened kind of fit within this framework, where the efforts that have targeted patients, particularly efforts that have targeted providers, and efforts that have targeted payers. In this case, the counties that participated in the HCCI and the LIP programs, as well as particularly those. And then in terms of the efforts that have gone towards targeting these individuals, care management services that have targeted patients, particularly patient-centered medical home, or an approximation, an effort towards that type of change that has targeted both individuals as well as providers, and also larger efforts that have led to system building. These are the particular programs that I'm going to talk about, and I think everybody is pretty familiar, so I'm not going to provide detail. Am I pointing in the wrong direction? There you go. Particularly, and I will provide examples from the different programs, HCCI and the Low-Income Health Program both had significant effort towards creating a network of providers. And that was just something brand new within the safety net, and a lot of different components within this that are worthy of mention, particularly efforts towards including third-party administrators, PBMs, referral guideline development, access monitoring, and a variety of other innovations. Particularly under the infrastructure building, under the low-income health program, promoting access to enhanced services with some, as listed in the graph, as you can see, administering health risk assessments, offering oral health prevention programs, offering disease and care management programs. Particularly, there were 10 counties participating. A lot of them put a lot of effort into these particular types of activities. HIT resources to support care delivery. Again, a lot of these organizations, the counties did not have a lot of resources to provide HIT beyond the county systems, but they did a lot of work towards expanding that capacity, including providing electronic referral management, including providing clinical decision support, clinical care guidelines and protocols, etc. A lot of work that went towards changing patterns of care delivery, particularly, for example, counties that provided pay for performance to the providers, providing referral management policies, clinical care guidelines, anywhere from adopting existing guidelines to modifying existing guidelines to actually developing guidelines from scratch. Training PCPs on extending scope of practice, trying to avoid sending patients to specialists when a lot of the work could be done at the primary care level before sending patients to specialists, trying to avoid some of those long backlog of specialty access. Performing a lot of performance review of the providers, trying to guide providers on how to do care delivery. Promoting behavioral health integration into primary care, co-locating primary care providers into the mental health specialty centers and providers, or vice versa, providing social workers, co-locating social workers into primary care settings. Moving on to some of the tremendous accomplishments here, just simply in terms of enrollment, as you can see, but not just that, but trying to improve outreach into providing, enrolling more populations, as well as doing a lot of work to try to avoid churn, try to re-enroll patients and not lose them from the program. A lot of interesting outcomes that came out of the program. HCCI final report has already been released, and there were some very interesting trends that everybody's interested in. A significant and clear reduction in the number of hospitalizations compared to the baseline period for a cohort of the population that was enrolled in the program for the entire length, as well as those that were enrolled for a shorter time period. And as you can see, there's a decline during the program as well as compared to the baseline. Similarly, for the emergency room visits, ED visits, there is a decline from the baseline to the program period. And in this slide, you don't see the change in the, or a decline during the program, but in a follow-up study where we actually controlled for the population characteristics, you see an initial pent-up demand, increased use of ED, but a decline over time by the third year. Looking at the patterns of care in the outpatient services, again, a similar pattern to as I just described, a decline over the program, more appropriate utilization of services. And a little bit more about some of the processes of care. Particularly, we just did not have a lot of data to look at all of the different changes, but looking at the processes of care quality improvement. Okay, I'm supposed to stop, but a little bit about the district program where we, this is only from the interim report, so a lot of that information, the final report is going to be released in October of this year to CMS. But I think what is interesting to note is that triangle in the middle that highlights the kind of programs that the public hospitals particularly focused on: primary care improvement, disease management, patient-centered medical home, among the two of them. Oh, okay, too late. And also, a little bit about, these are perceptions of the public hospitals in terms of care delivery, what they felt the district effort did for them, particularly improvements in quality, followed by improvements in patient outcomes and increasing efficiency. And last one is, these are again what the hospitals told us about the impact of the program, systematic and major change in their systems, obviously a lot of transformation, operations and information technology, and of course infusion of resources into the hospital system to make those things possible. And if I just wanted to highlight some of the publications that have come out of these efforts to date. But one overall observation, I want to end with that, is that obviously the funding was the major catalyst that made all of this work possible. But what was most impressive is the level of effort that was put in above and beyond the basic requirements of these programs by the counties and the hospitals, and the innovativeness that people approached these efforts. And I think that was most impressive, and it bodes well for where California is likely to go because of individuals that are willing to go that extra mile. Thank you.
Well, thank you. It's a pleasure to be here. I'm Michael Gusmano. I'm going to speak with you about district waivers that have taken place in other states, so I'm less likely to get myself in trouble by speaking to this audience about California since I'm located in New York. What I'm going to do in the few minutes that I have is mention a couple of features of district waivers that are common to all of them, and then talk about 3 lessons or at least opportunities that I've seen. And I should say this is based on research that I conducted with Frank Thompson from Rutgers University, and we will be in the July issue of Health Affairs, so please use your discount cards and take a look. As you know, district is now underway. California, as is often the case, has taken the lead in 2010 in creating the district program, and a number of states have replicated this. So you have California, Kansas with a very small program, Massachusetts, New Jersey, New York, and Texas. They are all part of these broader 1115 demonstration waivers, and they all in some way or another try to incorporate some version of pay for performance, and that's the first feature I want to talk about. One of the things for me as a political scientist that's quite interesting is that in many ways the enthusiasm for P has sort of gone beyond what the data and the evidence actually tell us. There is some positive evidence to suggest that pay for performance can lead to important changes. You've heard about some of them, but overall I would characterize the research that's been done on P as mixed. both in terms of NCQA efforts, CMS efforts. Most of the studies show that in some instances, the incentives lead to better outcomes, and others, they lead to worse outcomes. Beyond that, while we do know in some instances that there have been positive changes in a pre-post way, most of this hasn't been done with controls, and so there's always concern about whether the incentives were what was driving this. One of the critical assessments of the CMS experiment in 2007 suggested that hospitals that didn't participate actually did better than hospitals that did participate, so there was a positive change over time, but it didn't seem to be driven necessarily by the financial incentives. You have the usual sort of array of concerns about P4P that are still with us, but I'm going to come back to why I don't think this is all negative in just a moment. And one of the concerns is the proverbial drunk under the lamppost concern, which is that not everything that we care about and value in healthcare can be easily measured, and so doing more to collect better data and think more carefully about metrics that we use is something that's ongoing and important. The other concern, quite frankly, is whether we're measuring the right things. One of the more interesting studies on P4P was done by Coleman and colleagues that looked at diabetes management, which is part of most of, I believe, the DSRIP waivers. And what they found is that P4P incentives were quite good at improving HEDIS measures. So, for example, you had an increase, a dramatic increase, actually, in ordering hemoglobin A1C tests. But it turns out that the same patients were not doing a better job of controlling their blood sugar. So more tests, not necessarily better blood sugar. So getting a better handle on that is an important challenge for all of these states moving forward. The other really important feature I wanted to mention of the DSRIP programs is that there's been a division. Most of them sort of follow the California model in what we call hospital-centric approaches. Now, you've already heard from Dr. Peratt that, in fact, despite the fact that the incentives are targeted to hospital systems, there's been a lot of effort in California to develop broader networks and reach beyond the hospital. And that's true in all of the hospital-centric systems. But more recently in Texas first and just in the past year in New York, there has been an effort to develop what we call sort of regional network models, which is to say that CMS is no longer taking on faith that if they provide financial incentives to hospitals that do things that ought to require more integrated care and better coordination with outpatient providers, that will happen. They're now requiring the establishment of these networks. Now, what I can't tell you is that this approach works any better than the hospital-centric model. In fact, most of my talk is about what I don't know. But indeed, there is some positive, kind of more qualitative findings from this. So we did, in addition to extensive document review, we did a lot of interviews with both advocates, community-based providers, hospitals, and people from the Medicaid agencies in Texas and New York. And there is a lot of enthusiasm about what this network model has generated. And I will just end with 3 quick lessons. First, as I mentioned before, I really do think it is extremely helpful and important that as part of the DSRIP waiver process, we are collecting a lot of information about what's happening in the healthcare system and information that should allow us, in fact, to look much more carefully about the role of P4P. It's somewhat disheartening to think that John Wenberg and colleagues first identified unexplained small variation in the practice of medicine 43 years ago in a Science magazine article, and if you look at the numbers, the level of unexplained small area variation in most parts of the U.S. is actually bigger than it was over 40 years ago. We're still trying to figure this out, so the evidence base for evidence-based medicine largely doesn't exist, and so DSRIP can really contribute to this by collecting better information. Second, I would say, even in the hospital-centric models like California, but particularly in Texas and New York, we've heard tales about the establishment of much stronger relationships between hospitals and outpatient providers, even social service providers. The integration of mental health and primary care, I think, is something that everyone mentioned to us as an exciting prospect. This is something people have been writing about for decades, and it's actually finally coming to fruition, and I think that's a positive step forward. I will say in New York, a lot of the community-based providers and advocates are deeply, there's less cooperation in New York than there is in California generally, and I would say that they are deeply skeptical about whether the hospitals will play nicely and share the money. And so even though they're supposed to, there's a kind of lingering concern. And then finally, I would say one of the weakest parts of most 1115 waivers over the past several decades has been that even though they are demonstration projects that are supposed to incorporate evaluation, the evaluation components have really been the weakest link. Where in California, the RAND study is something we are still citing, even though it's a little bit long in the tooth at this point. And so even when evaluations produce what might be thought of as negative results, RAND thought that providing people with greater out-of-pocket payments would lead to more efficient care, and that's not what they showed. I think the more we can learn about the value of these networks and the value of P4P, the better. And so I would absolutely encourage California not to shy away from evaluating what you're doing. Thank you very much.
Good morning, everyone. Thank you for the opportunity to present here today. I think I was invited in part because of publication I've also enjoyed having in Health Affairs that addressed P4P, looking at Medi-Cal managed care. But I'm not going to speak about that today, but I encourage you to take a look at that. After speaking with Alan and others, I thought it would be a nice opportunity to also tell you about some of the other work we've been doing in the state, looking at a couple of other, I think, important aspects when it comes to looking at waivers and thinking about them. So I'm going to talk a little bit about integrating long-term services and supports. And one of the things I'm going to emphasize is also the very special role that counties play in our state in terms of bringing about change. That is a very, all right. There we go. California's had a long-term service and support waiver policy under the current waiver, and the state has been pursuing greater integration of long-term services and supports with acute and post-acute care services. And as you all know, we have developed something called the Coordinated Care Initiative, which has, among other things, called for the mandatory enrollment of duals, those with Medicare and Medicaid, into managed care in a limited number of counties. And this is very common in how we have implemented many waivers. We do it at a county level and test it out there before we think about whether, in fact, it's applicable statewide. We are also including long-term service and support spending as part of the Medi-Cal managed care benefits. So we are sort of putting a budget behind long-term services and supports on a population basis. And to give you some feel for how significant Medi-Cal is as a player with regard to long-term services and supports, this is the entire population. It's from 2008, and that's going to be another thing I'm going to emphasize here, which is that I think something that's really going to be critical is to be able to speed up our capacity to get data from the state out to all of us so that we can understand more in real time what's going on. But this provides a very valuable baseline for understanding the impact of the waiver and what it's been doing. So in 2008, there were 430,000 Medi-Cal and Medicare dual beneficiaries. 430,000 who were getting long-term service and supports from Medi-Cal, of whom about 3/4 were dual eligible. We spent over $18 billion on that population, and this pie shows how it was broken out in terms of both the Medicare and the Medi-Cal spending. And I want to point out to you that on the right-hand side at around 3 o'clock, you can see that Medi-Cal spending on long-term service and supports was about 1/3 of the $18 billion, so over $6 billion was spent in that year on long-term service and supports. Medi-Cal also contributed to acute care spending and other parts of spending, and then the other elements were paid for by the Medicare program. What we are doing is in initiating long-term service and supports, if you look at how many people actually start initiating long-term service supports on an annual basis, 5.8% of the dual population on an annual basis enter into the long-term services and supports of the Medi-Cal program. And if you adjust for the health risk, the duals cost about $3,000 more per month when they receive care in a nursing facility than when they do receive that type of service in home and community-based services. So you can see that there's a lot of potential savings, aside from the fact that individuals prefer to receive that treatment in the community. Now, some of that cost difference could, of course, be that, gee, are the people who go to nursing facilities sicker individuals and therefore would cost more anyway? That's a real possibility, but we've been exploring that, and I'm going to show you some of the data related to that. It's also interesting to point out that 45% of the duals who enter nursing facilities never had a trial of home and community-based services ahead of time. So we just go straight into the nursing home and maybe are missing an opportunity to take advantage of that sort of intervention. And so if we integrated care more effectively, perhaps we would be able to identify individuals earlier, treat them in the community before we have to use the more expensive nursing home care. Now, I mentioned that we use counties a great deal to study and implement some of our changes. So let's just take a look at some of the variation that we see among some of our largest counties in the state. This is the rate at which we initiate long-term services and supports across some of our largest counties, LA at the top, Kern County down toward the bottom. And these are the rates on a population basis, given the number of duals in each of these counties, starting long-term services and supports. And you can see the red bar, vertical bar toward the right-hand side is the average rate across the entire state. Los Angeles has a slightly higher rate on average of using LTSS compared to, say, Kern County at the bottom, which has a well below average use of LTSS. Now, if you further break that out by the type of LTSS, what you see is the dark bar, part of the bar, represents how much of this LTSS is home and community-based services, and the hash bar is how much of it is delivered through nursing facilities. And so again, you can see while Los Angeles uses the most amount of LTSS, they also are above average in using the amount of home and community-based services compared to the statewide average, which is the red bar going down. So there's quite a bit of variation across counties in terms of how much LTSS is used and in the type of LTSS that's used. Now, again, I brought up that maybe there are differences in the underlying health characteristics of people in different counties that could explain some of this. So what we did was we built a model looking at the demographics, like the age of the individuals. We took account of the kind of diagnoses and how much morbidity they have. We were able to measure their functional status in terms of ADLs. We were able to look at their social status, whether they live alone or have other people living with them. And we were able to therefore create a predicted amount of use of nursing facility use relative to home and community-based service use on a statewide basis. And that's what that vertical line is of predicted nursing facility use. 1.0 would represent that you're doing it exactly at the statewide average. And what you can see is that we have 3 counties of the 10 that I've portrayed here that, given the expected amount of nursing facility use relative to home and community services, they're much higher than average. And that is Santa Clara, Riverside, and San Diego. And then we have toward the bottom 2 counties, Los Angeles and Fresno, that based on what their predicted amount of nursing facility use relative to home and community services are actually below the average. So there's real variation in how counties end up using these kinds of services. So I just want to close by saying that when it comes to implementing waivers through counties, waivers do have a great benefit in terms of giving flexibility to counties to try new ideas, to address inefficient practice variation. What we are doing in many of our waivers is moving financial responsibility to the local level. But unfortunately, I think we have been slow in some cases of getting data and analytic tools to counties to help them know how to not just figure out what to do with the money, but how to most effectively use the resources they have to really meet the needs of their patient populations. And I believe California may benefit by establishing greater data sharing capabilities to support population management and program evaluation at the county level going forward. Thank you very much.
Thank you for those presentations. Keeping the focus sort of on the evidence, let me just try to get a little conversation going, and then we'll have a few minutes also for those of you in the room. I want to pick up on Michael's comment about saying all the things we don't know, and bring the other two of you in and sort of ask, given his presentation and given that the two of you are here in California, can you weigh in on your sense of the degree to which we do have an evidence base? Would you basically generally agree with his observation that we're a little bit out in front, or do you feel like the work you've done, which both of you presented, gives you a little bit more confidence about the evidence base for what it takes to improve care? How's that for an easy question to start with?
Well, I guess I could speak about the evaluations of the healthcare coverage initiative and the low-income health program, which we've spent a lot of time looking at actual data, really as rigorous evaluations and evidence-based as best that you can, given the data that's available from administrative data, claims data, enrollment data. And I think we're doing more and more in-depth analysis. Obviously, the first reports are kind of overarching and provide a lot of basic information, but the more we dig in, the more we find really interesting evidence of how the programs work very effectively. So from my perspective, we're getting really good information. District is a little bit different because district did not have, the evaluation does not include first-hand analysis of the actual data from claims. It's a really different type of evaluation and different ability to look at the information, but still we're finding some very interesting results, and of course remains to be seen what the final report shows. We're able to do some external analysis with available data in California to see what was the impact of the program. So I think we're doing really well given the opportunities that we have.
You know, I guess I would say to some extent, and my presentation reflects this a little bit, I think we are underachieving to some extent what we could do given the amount of state data that we have. I think there are delays in the availability of that information, and too often I think the data is used as, oh, can we get a final evaluation of what we did, as opposed to setting it up as a tool that could allow us to do much more rapid cycle evaluation of what's going on. I think there are a lot of barriers to how to bring the data together. I didn't get into this at all in my presentation, but this required bringing together 19 data sets to be able to do the kind of information here. It's very cumbersome to go through the process of getting all those data use agreements in place and to get permissions and to sort of take the perfect photograph, when in fact what we should have is much more of a video surveillance camera that's going on with our system all the time. And I think we're quite capable of doing that if we move away from this mentality of let's get the data at the end to see how we did, and move much more to how do we get the data up front and provide it. Not just, I mean, I think the departments need to have it to run their programs, but I also think it's a really powerful tool that were the stakeholders allowed to get more access to it in combination with people who really know how to navigate these sorts of data, I think we would stimulate more innovation about how we could in fact transform our system, and that would get a more rapid feedback. So I think this is a really important area of healthcare innovation, is how do we in fact safely produce and use the data in a much more real-time fashion. And I think California could take advantage of this, and it would really be helpful for transforming our system.
Yeah, I just would like to echo that. I spend about half of my time doing international comparisons of health systems, and remarkably, I would say you have more information and better information about your health system available to you in California than a lot of national health insurance systems. That is a comment on some of the data available in national health insurance systems to a degree, but it also speaks to the fact that you could, as Dr. Vindman suggests, take much greater advantage of what you already have right here.
It's always good to be graded on a curve, isn't it? Andy, you took the issue of the role of counties front and center in your presentation. That's a long-standing topic in California. Without sort of getting into the history of it, I'm just wondering what the implications are, taking what you did, focusing on long-term services supports, as we think about the waiver writ large, and how you would sort of map your work that you presented to the broader issue of, and maybe to tie it also into the data questions of how to make sure that the state is taking as much advantage as possible of the role of the counties. Well,
I think a critical factor here is, I mean, I think it's brilliant to take advantage in such a large state as ours to engage counties and to try out new ideas in counties. I mean, there's so much excitement at a local level to recognize the differences and what the resources are and how to use them in different kinds of ways. We should absolutely be doing that. But I think what we're struggling with a little bit, and I'd be really interested in the next panel when we have Mitch Katz and other leaders from counties speaking about this, to be able to I think we need to not just move financial responsibility onto counties, but to figure out what is the role of the state to be able to organize this data and to make it more readily available to counties. Counties can do a lot with their own data. What they can't do effectively on their own is to benchmark their performance in the kinds of ways that I was able to show in my presentation. And I think there's a really valuable role that needs to go on, again, in more real time, of being able to share with counties, gee, this is how you're doing compared to the rest of the state or to other counties that you think are similar to your own. That could, again, allow for hypothesis generation, allow for shared learning in different kinds of ways of trying different kinds of things. So I think we have the setup for a brilliant set of experiments and innovation in different levels of counties, but we haven't really set up the system yet of pushing the data back out to the counties in a way that allows to support the kinds of decision making they have to do. I think the counties do an unbelievable job given how much they're flying blind in many cases, and I think it's a matter of really aligning our state resources to better support that through data and so forth with these kinds of changes.
Other thoughts about the county role? Anything from the...
Well, actually, I wanted to follow up what Andy's suggesting. Obviously, is a great idea, and the counties, I think, did a lot of work towards improving their IT systems so that they can actually have the kind of data. So we were getting that information. We tried to develop dashboards where we would provide the information back to the participating counties so they could see how they're performing in connection with the others. It takes a tremendous amount of energy and resource to do so. So, you know, the idea of having a systematic approach to that and building that as a regular activity instead of a one-off during an evaluation sounds like a really good idea.
You can always count on a health affairs event saying we need more data. Let's open it up to questions that you all might have. I can keep going, but I see one in the back. And please let us know who you are. We have time for a few of these, and then we'll move into the second panel.
Gil O'Hara, Director of CPAC, as School Public Health, UC Berkeley, and a very willing participant of CAMRI, California Medicaid Research Institute. I'd like to follow up again on the data issue. Is that it seems to me a logical thing that should be happening as part of the waiver is a key element of the package ought to be a transformation and an updating of what data is made available and who it's made available to. And I think that we CAMRI could help in that process of doing some kind of return of investment, ROI, to suggest that the dollars to be returned, okay, would be significant. It would be go a big step forward to that issue of neutrality, of budget neutrality. So it's a suggestion, and we've been part of the CAMRI process since 2004. Thank you.
Someone up here?
Hi.
Let's get you the mic.
Hi, Skip Snow, Healthcare IT News. I'm hearing two sets of issues around the data. I'm hearing the business legal issues, and I'm hearing the technical, how do you put 19 data sets together issues. Could anyone on the panel discuss the technical issues rather than the legal and business issues?
I'd be happy to talk about the technical issues. Is there something in particular that you're wondering about, or?
Well, I just can't imagine how difficult it must be to put 19 data sets together in a technical way where the data actually matches and makes sense and so on and so forth.
Actually, so let me just say a little bit about we do have extraordinary data in our state, and it's not to say it's perfection. It's a lot of our data is driven by the operational activities of what go on with these programs, but it's quite possible to link the data sets, which is what the essence was of how this kind of work is done. I would say that some of these data and what I showed you came from the federal government as well, because we're talking about duals, and the Medicare program is the responsibility of the federal government. But there are identifiers in these data sets that allow for linkage and identifying of the same individual. There's also ways of handling that data in a very safe way that protects the privacy of individuals, because it's never important. Nothing I showed you was important that you knew the name of a single person who got that service. It was about showing you on a population rate what happens. And that's all quite possible to do, to set up those kinds of things. So yes, it does take some technical expertise, which we have at the university, to be able to do those kinds of data linkages and to manage millions and millions of records to create those kinds of things. You also need to have intelligence about the programs to understand and to work in partnership, ideally with leaders in the department at the state who can tell you some of the fine details of the data sets and what different things mean in different fields and so forth, and then to standardize the measures of what's used across different counties and to talk with county leaders about what's meaningful to them. I showed you some measures here about long-term service and support issues. We had a stakeholder process that people told us about the kinds of things that would be important. But that's what you would need to then be able to create from all this big data useful information to actually drive the program. So I don't think the technical barriers are that significant if we could work in partnership. The university is a natural partner with the state, but there could be others as well, about, again, keeping the data safe, but also linking it together in some ways. And the process of doing it quickly is very much within our grasp. I mean, the big data time is here. California has a fantastic data set in a variety of different places, and it's a matter of just bringing it together and then making it available on a timely way to key stakeholders so they can make it actionable.
And if I could just follow up on that last point about who gets the data, Texas is an interesting comparator for California because, of course, counties play a significant role there. And one of the things that we are seeing in Texas is that hospitals are often, sometimes it's county government, but hospitals are usually taking the lead as part of their regional networks. And one of the efforts in terms of infrastructure building that you've also seen here in California is an effort to get the hospitals to sort of share their capacity and enhance the capacity of other community-based providers to do this.
Jill Yegan with the Integrated Healthcare Association. And I'm wondering, given all the effort that you all have invested in looking back and assessing the progress and learning sort of globally, what have we learned from this last phase? And then applying that to the forward-looking waiver and sort of harking back to what Peter asked about where we're going. Otherwise, we'll surely get wherever that is. What guidance, if you had, some time with the DHS director and the CMS director, what would you sort of provide in terms of guidance about what we've learned from the last 5 years to inform the next 5 years?
Okay. So, great question, Jill. I think one of the observations that I would like to point out is there was a lot of different things that the counties tried under the particularly CCI and the programs, lots of innovation, lots of interesting things. Once the programs ended, the funding went away, not everything necessarily is institutionalized for a number of different reasons. And I think that's what, it's sort of an opportunity that was there. There was a lot of great things done, but we will miss that opportunity in continuing to build on those. So whatever can be done that could keep those advances, the system building, all of those great things that happened. Some of it, I think, just went away because the programs just were no longer there. The people got enrolled in Medi-Cal, and the county was no longer responsible for those populations, so there was not a population there in some areas to continue those programs, and that's just an opportunity lost.
I guess I would say we are unbelievably fortunate in this state to have so many mission-driven people who are committed to try to have the right thing come out. I think we have a lot of people also with fantastic ideas, and I think we've seen some of those things play out. But I think we have missed, really to some extent, the opportunity to take advantage of the available information that exists today to actually test some of our ideas in a more ongoing way. And I think we are continuing to put good policy ideas out there and to pursue those, but maybe a little bit more in the religious realm than the scientific realm. And it's never going to be perfect. It would be absurd to pretend that we could drive policy purely in some scientific way. But I think we are in a new era where it is much more possible to get those things more closely aligned in a way. I think it's beyond the data. I think it also involves engagement and connection of people who know how to use data and to use them in partnership rather than see them as some person who comes along later to just provide some answer about what happened 8 years ago, but to in fact have them in an ongoing way as part of the decision-making process in the beginning. So this is a change of how organizations can start to use data to drive decision-making in a new way. Again, I think we're really fortunate that we have very bright people with great ideas, including many of you here in this room, but I think we have perhaps need to think about how do we as a management going forward start to think about new streams of information we could take advantage of that would allow us to correct more often than just an application every 5 years.
Fit what?
I'm a healthcare provider, and I'm curious in terms of how you collect data regarding quality of care. It's a very big concern of mine because I'm out in the field, and I can understand access to care, but especially with managed care, what's the data in terms of showing how that improves quality of care?
So we do have different data sets for that. We could certainly as a community discuss whether we think they're adequate or not, but we do have in managed care, we have access to HEDIS information, which is one form of information which is standardly collected. In the piece that I actually published in Health Affairs that I didn't talk about today, we actually took advantage of some of the individual level data that was collected from those different plans, and that information could be linked with other kinds of information. Our encounter and utilization data can also be used to create certain kinds of quality measures. I've been involved for a number of years with measures like preventable hospitalizations, for example, where you can look at individuals with chronic illness to see what are their rates of hospitalization. That gives you an insight into the degree to which they are getting adequate access to primary care to prevent the possibility of getting admitted for a chronic condition. So I do think there's actually a pretty vast repertoire of measures in quality that are available from the kinds of data sets that we already have, but that isn't to say we couldn't, again, as a community, improve those over time to bring in more patient experience measures and things like that. But I do think that we have a wealth of opportunity in the kinds of data sets we have already to do a lot of quality assessment, again, in much more of a real-time way.
Well, and in the more recent waivers, particularly in New York, there's been an aggressive push by CMS and to some degree New York State to incorporate exactly the sorts of measures that Andy was describing. So the federal money to New York State is tied to, over a 5-year period, a 25% reduction in avoidable hospitalizations, which is somewhat daunting, particularly if you people speak with the people of the Health and Hospitals Corporation in New York City, caring for a very sick population. But one of the things I think is common to all of these disrupt waivers is that really they are doing two things that move in somewhat opposite directions. One, they are trying to use these fairly well-established measures that we've been using for quite a while to look at quality using administrative data. The other thing, though, is with these local processes, they are trying to be as responsive as possible to what people care about at the local level. And so you do get a degree of variation, usually though with common metrics across the state.
I guess the challenge is really going beyond process measures and get into more outcome measures. That's probably the hardest. And by outcome, patient experiences, people are getting better at collecting that data, but getting to actually outcomes of, for patients with diabetes, reductions in blood glucose level, things like that. Those are a little bit more challenging, particularly with administrative data. Don't have that kind of information, so you need to get deeper into encounter data and health information data, health record, where you can do that kind of analysis.
So I think with the last two questions on how do we know quality when we see it, and what have we learned from the past, it's a good time to wrap up this first panel. Please join me in thanking our three speakers. We don't have a scheduled break because we're trying to make this an efficient use of a couple of hours. So I'm going to ask our second panelist to make your way up, and if we can get new name cards so that you're appropriately labeled. This is an opportunity now to transition from sort of what do we know, or in Michael Guzmano's words, what don't we know, or in Andy Beinman's words, more religion than evidence. But here we are in the real world, and it's time to do the best we can with what we have in the real world. What we thought we would do with this second panel is to just start with a very light touch on where we are. Most of you in the room, I suspect, keep up with where we are on a minute-by-minute, hour-by-hour basis, but I want to make sure everyone is aware of sort of the starting point. And then, because we have a variety of perspectives represented on this panel, we'll be able to get into a conversation more about sort of where do we go from here. So we are going to hear from Jennifer Kent, Director of the California Department of Health Care Services, the agency that is responsible for Medi-Cal, an obvious voice to have in the conversation. Brad Gilbert, CEO of Inland Empire Health Plan, one of the largest public not-for-profit health plans in California, with more than 500,000 members and a 3,000 provider network. We'll hear from Mitch Katz, who directs the LA County Department of Health Services, previously directing San Francisco City and County Department. Anthony Wright, Executive Director of Health Access, the statewide healthcare consumer advocacy coalition, where he has been since 2002. And Mary Cantwell, Chief Deputy Director of Healthcare Programs at the Department of Healthcare Services, responsible for running the Medi-Cal program. So it's really terrific that all of you have joined us, and we really appreciate your participation in today's event. Jennifer, let's just start with sort of a level setting, make sure everyone in the room knows where we are. You could take a day to do that, but we're just giving you a couple of minutes, and that'll get the conversation going.
Great. Good morning. So from the standpoint of where we are currently with the 1115 waiver is, it is the start of a process, and I was actually just talking to someone outside as we were waiting to come in here, and I said it's kind of like asking a woman that just found out that she's pregnant when she's checking into the hospital to actually give birth to her baby. We're a little premature in the process. So, waivers are very long, and they're complicated, and they're hard, and I've had the pleasure or the trial and tribulation of doing a couple of previous waivers with our state before, and they are at some points frustrating. They are sometimes bumpy. They are always and have been always successful. And so ultimately you keep your eye on the horizon, which is, we have a lot of really good and innovative things to do in this state, but getting there with the federal government sometimes is a very long and windy road, when you could have, of course, gone straight from point A to point B and gotten there in gotten to the same point, but sometimes we have to take the long way. So, where we are this week is that we received kind of a list of unofficial comments and questions from the federal government late last Friday. We're still going through it and trying to kind of put a framework and a process together with them for how we're going to get ourselves to the end of October with a new waiver. So, more on that later. I think, overall from the high level point, and I know a lot of you involved yourselves very deeply with our stakeholder process starting last year, which I think was really, in many cases, remarkable from the standpoint of when we submitted our waiver application this year, a lot of individuals and stakeholders and organizations knew what was in the waiver even before we sent it, which was indicative of how serious we took the work that we did with a lot of different entities and organizations. And so, in its highest level, I categorize our waiver as, Medi-Cal 2020 is actually a really great way to entitle it, because it implies not only the 5 years that we're looking towards, but it also implies a vision, which is we have settled the argument in California about whether or not we're going to cover populations, and instead we're talking about how we're going to cover those populations and how we're going to bring comprehensive integrated benefits to individuals, which I think is very different than what is happening in a lot of other states. CMS has told us this many times, which is the conversation that they are having with California is very different than the conversation they're having with Florida or other states. And so in many cases that sets us up for both success, but it also sets us up for a series of different challenges, which is, well, you guys have figured out how to cover people, so now tell us, what are you doing with individuals that have serious mental illness, and how are you integrating the benefits of those individuals and their needs on the medical side? And what are you doing to more meaningfully impact their lifespan, which, for a lot of individuals with serious mental illness, we know that they tend to die 20 to 25 years ahead of similarly situated individuals. And so I think the challenge for us as a state, the challenge for us as counties and health plans and hospitals and providers and all of the different facets of the healthcare industry is, how are we aligning ourselves so that we are all working together, and that the financial incentives, which are the underpinning of both the economy in the state as well as the provision of care, how are we aligning ourselves to make sure that everybody is actually working at the same purpose and that everybody is rewarded for doing really hard work. And so, with that, I would just like to say we have a lot of, hope and expectation for what we have put together with the federal government, and there's more to come in the months ahead.
Thank you, Jennifer, for getting us started. When we talked about what would be a good use of time, we realized that just as you said, the process from here to the end of the waiver is uncertain and quite fluid, and we could talk about it today, and half of what we said today might not be relevant tomorrow. So we agreed we would do a little thought experiment, which is, imagine the waiver has been approved. And the details are not exactly known, but the general framework is pretty well known. The dollar amount is certainly not known, but it's more than zero, probably by a significant amount. So it's the day after the waiver goes into effect. What is it that you, and I'm going to ask each of you in turn to take it from the perspective of where you sit. The waiver is in effect. What is it that you need to do to make sure that California achieves the goals that you've set forth for the waiver? Brad, let's start with you.
Sure. First, Alan, go Bears. And most importantly, don't knock grading on the curve, because it's how I got into medical school. So, very key at Berkeley. So a couple things. One is need to update the bio that's in the program. We have 1.1 million members, and we have over 4,000 providers as a reflection of that growth in membership. To me, I'm not starting the day of the waiver or the day after. I'm starting now because there's clear issues that need to be addressed that will be addressed in the waiver and are going to be part and parcel of what we need to do going forward. And I look at kind of two big issues, both of which relate to population health. One is access. We grew 450,000 members between December 2013 and today. 450,000 members. So we went from 625 to about 1,087,000, 75,000. So access for our members is really key. The second is integration, crossing and coordinating between all of the services that our members experience and deal with. Physical health, behavioral health, long-term support services, as was mentioned earlier, social services. How do we make sure that we're looking at a member, we call them members, across all of those care providers and care systems so that we're organizing ourselves and delivering care in an integrated process to the member. The member doesn't really care that there's caregivers here, there's providers there. They want to be taken care of across their continuum of need. So that's real key. And then you think about within just the physical health system, PCP, specialists, inpatient, skilled nursing facility, transitions of care back. I mean, Dr. Perot said that there's been integration. I have two big counties. I think they're better than they were, but they have a long way to go. They really do. And I think there has been improvement. Now, when I think of data, I kind of focus on microdata. I think Dr. Binman is very much correct that it would be extremely helpful for us to have organized data across systems so I can see how our two counties are doing. But I focus on microdata, which is data across systems, right? So, you know what? You can share behavioral health data with physical health providers. We did our own local study. CHCF did a study. There's this myth out there about HIPAA. Can't share, can't share. Not true. Substance abuse, a little more complicated because of a federal law. But mental health services, physical health services, absolutely can share data electronically, by phone, whatever. So I think of that kind of micro data, both sharing across, and we've got to get better at that. And number two, I think about data within the system. So I'm a primary care clinic. I need to know who are my sickest patients, who are my patients most at risk, who are my patients that have behavioral health services, who are my patients that have long-term support services. And as Dr. Binman put so well, those are in multiple data systems. And pulling those together so it's actionable at point of care. So the primary care provider or the behavioral health provider knows what that member is experiencing from a care delivery system is really key. So I kind of get focused on point of care case management, registries, data analytics that allow actionable data at point of care because that's where the rubber hits the road. So what are we doing to get ready? Well, one thing is, I think the DSRIP in some of the comments that were made, one of the things that was not so good in the 2010 waiver was the coordination between the county hospitals and the plans around the DSRIP. They weren't aligned necessarily. So some of the goals, all good goals for the DSRIP, not necessarily aligned with the health plans. I have all the members. So we need to have that alignment between the counties and the plans. So what are we doing? Number one, possibly amazing thing, they're talking about the formation of a clinically integrated network between Loma Linda, massive academic center, and our two counties. Think about that concept. Two counties and a private academic medical center getting together and creating a single clinically integrated network. Long way to go, but good goal. Two, board gave me $8 million to subsidize new physicians in the Inland Empire, both primary care specialists, and I just added mid-level providers. So I provide subsidy for entities to hire doctors and mid-levels to increase access. Third, behavioral health integration. Jennifer Clancy's in the room. My board just gave me $10 million for 2 years, $10 million a year for 2 years to do 33 sites, big pilot with evaluation, both ongoing and eventual. I like that comment, don't study it 2 years after you got it done, or 5 years. Behavioral health integration, co-location, integration, delivery in one place, or very tight linkages. I've got a board and care, I've got a CBAS center, I've got a multiple county mental health centers, I've got a private mental health delivery clinic, I've got county clinics, primary care clinics, and FQHCs as part of those 34 sites, excuse me. So that's one of the things we're going to do. So I'm doing that all before because obviously that's a big goal in the waiver. Last, not least, is there is a possibility that the 2 counties and Loma Linda will be on one medical record system, Epic. Riverside's already bought off on it. $53 million the county's going to spend. San Bernardino, I'm crossing my fingers, hopefully within a couple weeks. Think about that concept. Single medical record. Single medical record between 3 large integrated systems, so that would be amazing. We're providing some funding and support for that. So to me, those are the pieces. This is all about that whole person care, which is the current term of something that those of us in medicine have talked about forever, which is you've got to take care of the whole person. That's what I see in terms of prep and getting ready for the waiver.
Great. Mitch, can you give us a county perspective?
So when I think about LA and the waiver that we're finishing, clearly, and people have talked about this, access huge gain. And certainly on the ground level, I see patients, they come in and they say, you know, I lost my insurance, I'm so glad I can come here, I'm so glad I have Medicaid. And I think that's really been terrific. I also think, we haven't talked much about it, but the hospital specific measures have been a success. They're easier in some ways to do because they're so concrete, right? If you prevent a certain number of line sepsis cases by improving your technique and through better equipment, you actually save lives, and there's no question, but then it ends, right? There are only so many things that work in that way, and we should be proud of those things we should do, and those things should be institutionalized. I think when you start talking about the broader healthcare system, part of the challenge is medicine and clinical care in general needs a certain amount of humility about what we actually can do. I mean, to me, as a primary care physician, and the thing I most try to get across to my staff, the single most important thing is for your patients to feel that you care about them, right? That's what people want to know. They're coming for care. They want to feel that you care about them. And what you can do by caring about people is incredibly therapeutic, because it turns out that most of the things that we do in medicine don't have a major impact in terms of chronic illness. I mean, there are the exceptions. There are the people for whom they have sepsis and you give them antibiotics and they get better. There are the people who have trauma and they fall off the ladder and you sew them back together and they get better. But that's not most of what American medicine is about, right? Most of American medicine is diabetes and heart disease and arthritis and serious mental illness, and those things don't fit that other model. So the one thing that I feel certain about is that if you care about people, they will feel better. And they will feel satisfied with their care if they know that you've cared about them. And that's part of the challenge about, you know, being too much sort of talking heads about systems when the healing occurs, and it does not by any means have to be a doctor. I've seen it happen between a patient and a receptionist. Right. It's purely the question of whether or not people feel cared for in the settings that they're going. And on integration, I think there too, it's a fascinating thing. You know, the patients, they don't have any problem, right? They come integrated, right? The person is before you. They bring you the problem, right? The problem is they can't sleep. The problem is they're in terrible pain. The problem is they're anxious, they're worried. The problem is they're homeless. The problem is someone's after them. That they bring the problem completely integrated. It is only us who can't deal with it, right? It is entirely a problem of the service providers, because we, among ourselves, have created language and barriers that prevents us from dealing with people who really just want us to deal with their problem. And some of it can occur through learning. So I'll end with one positive example that I think also supports the idea of rapid learning. We did a co-location project, mental health clinicians at primary care, and we found that actually they got relatively few referrals. Mental health felt like, well, what are we doing here if the primary care physicians are not sending us people? And after all, primary care physicians had said we have all these people with mental health issues. And what we think the problem is, neither the patient nor the physician necessarily conceptualized it as a mental health problem. So now what we want to say is we want the mental health people to train the nurse case managers on how to care for people who have physical illness and mental illness. So you're not sending, it's not about a different profession, it's about training people to do the work. Thank you.
Great. Anthony, what are you going to do to keep this all on track for the patients?
Thank you. My name is Anthony Wright. I'm the Executive Director of Health Access California, the statewide consumer advocacy coalition, also one of those integrated humans. I have a lot to say, have some points to say about integration and health system transformation, but I would be remiss if I didn't just point out that even with all the focus that needs to be on that, we can't forget that we will continue to have a remaining uninsured population. We haven't quite figured out how to cover everybody. I know there's lots of exciting conversations at both the state and county level on that, and we're very excited about the prospect of the waiver in having an explosion of additional county conversations, particularly the part of the waiver that talks about getting more flexibility for safety net care pool and DISH dollars, and using that for a broader range of services for the remaining uninsured population, we think could really provide a real boost to county-level conversations that are going on now about how to reorient our safety net, our indigent care programs, and how to make them not just broader, but also smarter in terms of how they provide the care. We've already had some exciting models. Mitch in LA with the My Health LA, which I believe covers over 100,000 people now.
We're past 100,000, will be 140,000 in a few months.
Just an exciting model there, building off of the model of the HCCI and the LIP, which was mentioned in the earlier panel. LA really did take those lessons at infrastructure. We were hoping that other counties would. Unfortunately, the AB 85 formula that reallocates dollars, the county realignment dollars, puts some hindrances on that, and so we hope that this provides a mechanism so that it's not just Sacramento and Contra Costa that are looking at broadening their safety net, but it's a range of other counties as well. And so, that day of the waiver, we hope there will be already work going on at multiple counties doing that work around their safety net. But with regard to not just the safety net infrastructure, but also to the Medi-Cal, I mean, we obviously, the issue that Brad pointed out about access is critical, and in this new world, whether both in the context of the waiver and ongoing, we need to, if we are really moved into a managed care environment, then that means we need to have much more oversight and, sorry, Brad, and accountability on Medicaid managed care plans to provide that access that they are contracted to provide, and that is critical. We were active in passing bills last year on having more surveys of network adequacy and timely access this year in provider directories, and we need to continue that work, and the waiver will hopefully provide both resources and a structure for that continued work. And then with regard to the health system transformation work, I know the earlier panel was the one that was the academics who were arguing for more data and more analysis, and so I want to endorse that as the non-predictable person to make that that argument, and it's especially a couple of areas. One is, I think that in deciding what those metrics are, if we're going to pay for quality and outcomes rather than per patient or per procedure, which have all sorts of problematic incentives, then are we going to have those metrics that really do get at what we achieve the goals we want? And so that's why the goals have to be not just a triple aim, but the quadruple aim that includes equity. We can't have a system that encourages, that may actually devalue taking care of our most vulnerable. In a world of income inequality, in a world of all the issues, especially here in the great diversity in California, we need to have those metrics really focus in on cultural language, the various issues of inequality in our system. And then also, we just need this to be a transparent system for patients. That at the end of the day, patients, I think, would welcome this transformation. No patient wants to have a patient given the choice would love to have the less invasive procedure, take less prescription drugs, have the more effective medication, but they need to see that decisions being made are actually being made for their benefit rather than just to control costs, which in the past has been a legitimate, founded concern. And so if we want to make these changes sustainable and prevent the backlash that could ensue, we need to address issues of equity and make sure that this is transparent for patients so that it has the adoption and patients are not just having this transformation done to them, but are active partners in the process.
Great. So Mary, other than maybe taking an hour or two off after the waiver's granted.
She'll get the whole day.
Oh, a day? You'll give her a day? It's always good to have your boss on the panel. Give you a whole day. What's the state role at that point?
Sure, I was going to say I was going to sleep for at least a day, but apparently not more than a day since I only get a day off. That's all right. So, I mean, I think really I view our role as how do we help the people who are actually going to be doing the work. We're not going to be the ones on the ground really implementing this. It's going to be our plans. It's going to be our providers, our counties, our other community organizations that are really out there trying to work together. And I think I view our role mostly as how do we help them to come together? How do we provide the resources that they need to come together? I think, the one thing I'll focus on is we're very excited about the whole person care pilot concept. We think it is the first in the country to really look at how do we focus on the Medicaid population in an individual community that has high needs, including homelessness, risk of homelessness, mental illness, other social service needs, and figure out a way through a structure that's organized by Medicaid but isn't limited to Medicaid to really bring all the pieces together. And certainly all those organizations, our counties, our plans, our providers, are out there doing that work now, but they don't necessarily have the resources to come together and to build the systems. I mean, hearing Brad talk about what they're doing in his counties is exactly the kind of thing we want to support through this waiver. How do we have the data systems together so that we can collect the data that Anthony was talking about, it sounds like the prior panel was talking about, so that we have that to not only know what are the issues that people are facing, but how do we then measure how we're impacting and changing their lives. At the end of the day, really our waiver is focused on the person, sort of taking the change, even though we've been talking about delivery system transformation and changing Medicaid, at the end of the day, what we want to have happen is that an individual's life is better, their health is better, and their quality of life is better. And we think the whole person care pilot is really a way to get at that most intensely for the sort of highest need population. And so one of the areas I think we can be most helpful in as we sort of go through this process and working with the main entities of the plans in the counties who will then bring together the providers and the other community organizations and housing is to help them figure out what systems do they need, how do we have the data to come together from one system that can come to us, that can be transparent and available to everyone so we can see the change that's happening. And then the other piece, and I think several people have touched on this, is the financing of it all. Today, there is resources out there, that's resources in Medicaid, resources in social services, resources in housing and other places, but the financial incentives aren't always aligned. We have a bifurcated physical health and behavioral health system today where not necessarily the financial alignment exists, where, if we could do more in behavioral health, it could reduce physical health costs, but there's no sharing of that sort of savings. And so our view in the whole person care pilots is let's find a way to add a layer of funding that's incentive payments and shared savings so that everyone across the spectrum can benefit from the additional work that they're going to have to do. But it's going to be tied to actually changing what's happening in a person's life, so that someone who needs housing, we're finding a way to get them into housing, and not only do that, but through our plans and through our providers providing the supportive housing services, the case management that they're going to need in their home, and then figuring out what other healthcare needs do they have, and working with our plans and the providers there to get that. And so we think we can really bring the expertise in the financing to help figure out how does that money flow, how does it get allocated, and make sure that it's fairly allocated across all of the systems so that at the end of the day, everyone has what they need and the resources they need to actually come to the table. And so we're really excited about that and the impacts that we can have. And then I think the final thing, really, our job being how do we have this be something we can measure, sort of talking again about the data, that what are we trying to measure, what are we trying to accomplish, and how are we going to make sure that we can measure that, and knowing that up front. So I really think the first several months of the waiver are going to have to be focused on how do we make sure we're knowing before we start that we're actually going to be collecting the information that we need, and how do we work together with our partners to do that. So I believe that the department can really be a leader in that area and really help to drive the change that we're talking about.
Great. I have a feeling there may be some people in the audience who want to weigh in, but before I give them the chance, I want to push a little bit of a conversation here. I know Andy Beinman said we're fortunate to have so many mission-driven people in the state, and I know Michael Guzmano said it's not New York and it's not Florida, but you all sound way too happy. Anthony's brief comment about oversight notwithstanding, I couldn't hear any disagreement. Maybe it's because we didn't assume a number or something like that, but I want to push a little bit, setting dollars aside, that I will come back to. Where's the controversy over the allocation of responsibility, the allocation of accountability? You all seem to endorse the direction and you all seem to want to be part of it. But at the end of the day, if we're going to have transparency, if we're going to integrate, if we're going to have whole person care, there needs to be some sense that it's not just we're all doing it, it's that we have a part in it and we're willing to be responsible, accountable for our part in it. I just want to push a little bit harder on whether there's disagreement on those roles or whether you really feel you've sorted those roles out, and that's just going to be easy as could be.
Okay. I think I chided Jennifer too, not just Brad, but okay. I think on this issue of just picking up where Mary talked about just the work of whole person care, I think that there's an intellectual acceptance on the issue of that we need to move to more coordinated and more integrated forms of care. However, it's at this level, and to do it, at every other level down is going to be the most incredibly hard work possible. And so I don't know. Because there are administrative barriers, there are financial barriers, there are turf battles, there's just, and so it's going to take. It's not so even if we get the waiver in all of the glory of what Mary, wants or hopes, in terms of financial incentives and whatnot. I think it would require a remarkable amount of leadership at both the state level, but also in each county, to try to basically knock heads of various department heads and fiefdoms and financing streams and there's just 15 places where it could break down. And so I think that it's great that we have that goal out there, but I want to be clear that that this is a very ambitious undertaking. We're very excited by the prospect of whether it's the integration of health with behavioral health, and certainly then to going to other human services like housing across the board. I think that's where we would like to go, but let's not forget about it. And I think the other piece on all of these things is that I think it was mentioned before about the great diversity and energy that is at the county level, but we have been frustrated by the fact that because the counties are so varied, there is your experience in getting health care or frankly other human services in California depends on where you live. And as much as I appreciate working in some counties and trying to do the innovative stuff that a Healthy San Francisco or My Health LA or a Health Pack in Alameda provides, it's frustrating that we don't have sort of a certain equity of rights for people who live throughout our state. And I think that's another key point of tension. So it's both intra-county but also inter-county.
So, I am responsible for organizing the care for the 1.1 million members of IEHP. Not me personally, but many of my 1,350 employees. So, not to be crass, but money talks. And I agree that P4P, we have a really robust P4P program, multiple levels. Some parts of it work, some parts of it work better than others, some I'm not so sure about. But what I have found is that the connection of a relationship with dollars and accountability works. So if I have, for example, with my behavioral health integration project, I will have memorandums of understanding, contracts that require specific deliverables for the dollars that I'm going to give those sites to be able to do some of the hiring of staff to either co-locate or integrate or do additional things, care managers, clinical staff, et cetera. So those dollars will bind those sites to do, because to Anthony's point, I don't control the delivery of care in a county mental health clinic, but I can control what I'm giving them money for, and they have to deliver what I'm giving them money for. And so I got Jennifer and Mary here, so just give the money to IEHP and the health plans, and everything will be good. But that's the real key, is that we are very fragmented. There's many delivery systems. I mean, IHSS is a great example. I was very disturbed to see Riverside not so good on the slide. I am financially responsible for IHSS, but I don't deliver the program. And so figuring out how to bind us together, and I think dollars help to do that because everybody's resource strapped. So if I say, I'm willing to provide funds for you to do these things, you have to do those things. I hold you accountable to that. That starts the process. But it's got to go beyond that because there are not unlimited dollars. So I really agree. But for me, in California, it is the health plans that have the vast, vast majority of the membership we're talking about it. So ultimately, I feel we have that responsibility partnering with everybody else.
I mean, I think the biggest, hardest piece of this waiver is really getting to kind of what Mitch alluded to earlier, is that having patients feel that they're being cared for is a problem of time and money, right? And so when you have a third of your population in Medicaid today, and 9.2 or so million in managed care, you can certainly task Brad and his other plan colleagues with, kind of delivering the services, but ultimately they themselves have to rely on the physicians that they're contracting with to be the ones that care for these patients. And at a certain point, some of these individuals are really difficult, and they have difficult life circumstances. They may or may not show up for appointments. And trying to manage both the social and the medical needs of these individuals requires a lot of time, and sometimes that's not what physicians have, and so you're really having to stretch your system to include other types of providers, which has not always been something that physicians want to either acknowledge or work within. And so, there will, I think, ultimately be a fairly, there will be a transition that will be needed because we're all going to have to kind of work to care for these populations in a better way, and that's going to require everybody stretching. It requires the federal government to stretch to let us do certain things without the way that we've always done it. But then on the very ground level, we're going to be saying to these providers, be they behavioral health or primary care or specialty, you're going to have to work with a whole team of people to manage this individual. And so I think that's going to be where things really get, the rubber's going to hit the road, and the numbers and the data that we're tracking will show whether or not that's actually working.
Mitch, I do want to see if, from a county perspective and from a delivery side perspective, whether the handing the check to the plans I didn't see a flinch, I didn't see an eye roll or anything.
I think that the plans are not best at delivering care on the ground level. Sorry, Brad.
No,
I
that's
think
true. That's true.
that plans are necessary conduits of money, important for putting together networks, but I think are fairly irrelevant to what actually happens in terms of the exam room. And I think Jennifer has it right. I mean, part of the challenge, and I think my own profession has been guilty of this. The real, and if you've never seen it, it's hard to believe. The real issue is, as Jennifer talks about, the homeless person with the severe mental illness arrives in the office, and what the doctor says is, I'm really concerned that your alkaline phosphatase level was a little bit high. And we're going to be, I'm thinking that, you had the ultrasound and they thought it was okay, but there was this shadow over here. Oh yes, and now I'm going to send you to these other people, who are going to help you with your housing. And, the closest we have is, primary care. And it's why I really think that if you look at the studies, while P for P, sometimes it works, sometimes it doesn't, primary care consistently comes up as the way that people get better quality care for less money. And we could be creating a whole set of incentives that are around things, and these could be followed very well by a plan. What % of visits happen with the primary care provider, right? So in a year, no one's going to see their provider necessarily every time. Do they see them 11 of 12 times, or do they see them 1 of 12 times? And how can we deepen that involvement?
So, and I completely agree with Mitch. I mean, really, where
including the part about the plans being irrelevant?
Are irrelevant to the specific delivery of a patient-physician or patient-clinician interaction. I mean, Mitch is right, and I want to go back to something he said that's really important, is that, you know, I gave the commencement speech for Loma Linda School of Medicine, and my whole speech was exactly what Mitch said, that the millennials are going to have incredible access to more data than anybody's ever had before about their patients, and they're going to be better at using that data. But if they forget that it's all about the connection with the patient and the relationship and not looking at the alkaline phosphatase level, we've got a big problem. And so I think the plan creates the structure to enhance and support the delivery of the primary care, but it comes down to those individual interactions, and they have to be good and they have to be caring. I mean, Mitch is right.
I have to, now we're sounding a little bit more like New York, and it seems a little more appropriate.
I don't think so.
No, we're not yet. I want to ask a simple question that I know has a very complex answer, but we did sort of set aside the dollar issue, and then, Brad, you mentioned money talks. I mean, at the end of the day, is there willingness to reallocate financial resources to the parts of the system that yield the best improvements in outcomes in all the dimensions that we measure it, or is this sort of, is that too much to ask, or are we setting ourselves up with the structures that will make that kind of reallocation possible?
I'd just say last year, Los Angeles developed 800 units of supportive housing for chronically ill people using health dollars, and we're going to do 1,500 units in the next year. And that's not a waiver thing, that's just a realization that it is a better, more effective way of spending money for chronically ill homeless people.
I mean, I think, you know, from our perspective, what we've tried to propose as a part of this waiver is a path to a place 5 years from now where the way we're financing the care that's being delivered and who's getting what is going to be different. But that we worried about sort of saying, okay, let's just take the dollars we have now and reallocate them differently, that could break the system, that there would be providers who wouldn't be able to survive that, or counties or plans, or however that was going to work. We recognize that there are better ways to pay for the care that's being delivered, and we're hoping that through this additional investment that we're asking for, that we can demonstrate that, so that, you know, one of the questions we get from CMS is, well, what's going to happen 5 years from now? Are you just going to keep asking for lots and lots of money? And the answer to that is probably yes, but, you know, but it's also asking for it differently and believing, you know, certainly talking with Brad and the other plans, we know that there's probably a better way to pay them. I'm not saying it will be more, but just a different way to make sure that they have the flexibility to then provide the flexibility to the providers, to the counties, to actually deliver care differently. And so we really view this as, how do we go up so that there's no downside risk for anyone right now to try to invest and change, but that with the knowledge that that's going to inform how we do reimbursement and payment methodologies 5 years from now.
So I think that's key. I mean, Mitch in LA, and LA has done some pretty amazing things about housing. We're kind of dipping our toe into the water by doing recuperative care. So we're going to have relatively short-term places for individuals that are in the hospital that are homeless to go where they can actually get some medical delivery, you know, home health or whatever, and have a place to go, and then work on getting them more stable housing. Those are our dollars. They're not reimbursed by the state, so that's a risk. And so I think, Alan, to your point, we've got to come up with a model that says, I absolutely believe that's going to save me inpatient dollars. And so there's going to be ROI, I believe, and we'll measure it and find out. If there is, somehow the system, we should get credit for that, and that should be how we're paid, showing that we're using the dollars that we have as wisely as possible, even if we're doing something that is not strictly a medical cost.
Okay, who wants to join in with a question in the back? Please wait for the microphone. I'm going to suggest we do a few of these, and given the size of the panel and given that I took up all the time, let's get a couple of people's questions together and then a sort of a group answer. We maybe get through that a couple of times.
I'm Ken Saffer. I'm a family and addiction medicine physician from Contra Costa Health Services, working in safety nets forever. The quadruple aim is really of interest to me, and I thank you for bringing that up, Anthony. I first heard about it in terms of Tom Bodenheimer and colleagues talking about it in terms of caring for the providers, so that if you have a system where we're caring for patients, being empathic, what happens to the providers in the system, especially when finances and throughput, I hate that word, are important. And I think that empathy that we promote for patients has to be mirrored in our own workforce, especially in integrating areas such as substance use disorders, where there's a tremendous negative stigma. And I would ask, how are we going to do that? And I think some of the questions that were discussed are really non-issues. Barbara Starfield, 10 years or more ago, I've heard her talk, saying that primary care is really the way to go on all of these measures. So how are we going to then bring down to the level of providers and promote more providers? Because if we don't care for the providers, we won't have enough primary care providers, whether they are PAs or NPs and so on. Doctors really want to have MAs help us with the electronic health record, which slows us down, and we need to find ways to really humanize all levels of care. So there's a lot there probably for another seminar, but.
Hi, Carrie Sanders with the California Pan-Ethnic Health Network. We're a statewide multicultural health advocacy organization. And this question is really for Marie Cantwell. Just given that the majority of Medi-Cal beneficiaries are from communities of color, would love to hear how the state is looking at reducing health disparities, particularly through a quadruple aim approach, as Anthony mentioned with health access. Thanks.
Get one more in and then up.
I have a simple question. Can you speak to the overlap and coordination between ACA 2703, the health homes proposal, and the waiver content?
Mary, you want to start?
Okay, apparently I'm answering these. So with respect to the disparities question, I think one of the ways that we're really want that to be a part of what we're looking at is, again, back to the data. In order to actually know what's happening and how we're changing it, we need to make sure that the data we're going to be collecting as part of this waiver is inclusive of that information, is really stratified. And certainly we've begun work on that. As you start to look at the data the department's putting out, we have begun some of that stratification, and I think that we need to really amp that up for the waiver, and looking at the metrics and making sure that we're thinking of, do we need different metrics for different populations, whether it's based on acuity or other demographic characteristics. And so that is the way that we think we need to first look at it, is what is the data that we have, what other data do we need, and then how do we work with, again, our plans and our counties as our primary partners with the providers and other organizations underneath to target particular populations appropriately once we know what the data is telling us about those populations.
We're talking about 2703 and.
Sure.
Well, you have to.
So we view them certainly in significant alignment. Obviously, the timing is a slightly different from the sort of the waiver, obviously going to be starting on November 1st, and the health homes program that we're working on, particularly under the specific 2703 process, really more targeted for 2016. But the same elements of someone having a place to go to that is their primary health home, particularly obviously the populations that are targeted in 2703, and as you've heard, many of the proposals we have in the waiver also being targeted again on high risk, high utilizing populations, is that we believe that the health home program can fit well in the construct of what we're talking about in the waiver, what we're going to be asking plans and providers and counties to do. And so we view that as one piece of the broader delivery system change that we're looking at, and that it will just be integrated as part of that overall structure.
And just very quickly on both comments with regard to equity, I just don't think it can be stressed enough that as we go through the system, I know that we've, whether it was on hospital readmissions or on some of these other issues, we need to be very mindful that as we are paying for better performance, that, a patient as coming out of the Tenderloin is just going to have a very different experience and just may need a lot more support, may need a lot more investment in order to get to a place than another patient from another part of San Francisco. And so that is something that needs to be taken into account when we figure out these metrics. And to this broader question of, is there willing to have that reallocation? I think, some of it's in the plan. I know on the safety net care pool dish piece, there is actually a whole process to allocate points in the first year differently than in the third year in terms of, community-based solutions versus an emergency room-based treatment. It's always going to cost a significant amount to do the emergency room care, and you're always going to need that. But if there's at least some acknowledgement of those more community-based, prevention-based areas, I think that's appropriate. And I think it's easier to do at this moment of great transformation of the whole system. I mean, we just have, as has been stated often, including by our governor, we now have 12 million people in the Medi-Cal program. It's a fairly major expansion, and so we need, frankly, we need more of a lot of things to deal with that situation. So this is not a moment of zero sum. This is a moment of expansion in general. We're also coming out of a recession, and as the governor decides his budget, we hope that that's recognized in terms of investments in Medi-Cal. But I think that's it's a different context than if we're just reallocating exactly the same dollars for exactly the same population. The final thing I'll say is that we do need to recognize the changes in the Medi-Cal population. Diversity in terms of culture and language is important, but also just in terms of what the Medi-Cal program is. It is not, it's not your grandmother's Medi-Cal. It is not, it's no longer certain types of long-term, low-income children, parents, seniors, and people with disabilities. It's now the safety net for everybody. And we're going to have a different demographic in Medi-Cal that's going to have a very different expectation of service and of getting that empathy and that reaction. And so it will be interesting how many of these changes are demand-driven rather than through all the plans that we can come up with in a waiver.
So I want to comment on both the substance abuse and the comment by the Contra Costa physician. Part of why the doctor focuses on the alkaline phosphatase when they have a homeless, substance abusing, mentally ill, multiple chronic illness patient is because that's easy to do. And so I think, my discussion, I'm a physician, love our physicians, love the providers, but we've got to give you the resources and the help so that when that patient comes in with those multiple complexities, you have a mental health clinician that can provide consultation. You have a substance abuse counselor that person can see that day possibly, so that you have the ability to address, because there's no way one clinician could address the 16 things that are on the list. And so if we don't bring those additional resources to you as a primary care physician and figure out how to organize that well, the populations we're talking about will have a real tough time caring for them. And you will get very frustrated because you'll only be able to address the lab values, or, even if you're caring, even to Mitch's point, you really care, what resources do you have to handle their substance abuse right then and there other than referring? So I believe if we can get more resources, care management, some mental health and substance abuse clinical capabilities at the primary care site, that will really help. And at the mental health for the seriously mentally ill, primary care resources at that site.
So I believe in ending when you say you're going to end. We have not enough time to get another question in, but I do wonder if there are any additional thoughts on this topic before we close it out. None. Wow. Okay. Well, let me say then that we at Health Affairs were really thrilled to be able to be part of this. I'm trying to move us to our closing slides, if you can help me out there. It's, as I said, for us, it's a great opportunity to be out and where a real, live, timely health policy discussion is underway. We're appreciative of the Blue Shield of California Foundation, California Healthcare Foundation for making this possible, and remind you that that we will have an issue, the July issue will have a collection of articles on Medicaid as well. Please join me in thanking our panelists. And thank you all for participating in today's event.